Hello, everyone. I'm welcoming you all for our first journal club, which we have planned. As we mentioned before, the journal club will be concentrating more on the methodology and results section so that we can better understand the results and methodology. However, we'll be just going in a brief about the introduction and discussion. The article which I am going to present here was published in the Archives of Physical Medicine Rehabilitation. The study title is Effect of Dynamic Neural Stabilization on Balanced Tongue Function and Falling in Patients with Multiple Sclerosis or People with Multiple Sclerosis. It's a randomized controlled trial. So, what was the idea behind me to select this article is that first thing is that this article is published in a very high index journal. The archives, everyone knows that Archives of Physical Medicine Rehab. It's a Q1. Q1 means a Quarter 1 journal in the field of rehabilitation. And the title which attracted me was the dynamic neural stabilization. You know, that's a new technique which is used for in field of rehabilitation. And what I could understand is that this dynamic neural stabilization techniques are somewhat similar to the yoga techniques that we use, which we control the breathing techniques in combination with the movements of our upper limbs and lower limbs. So that attracted me, and for taking this article for presenting for the first journal club. So as we have discussed before, we would be just posting the screenshots of the important points here, which would make this journal club presentations for everyone easy to present. And even for the readers, I mean, even for the listeners, they can like enlarge the size of the screenshots to make it more better understandable. Here we can see the abstract of the article. The study was done comparing two groups. One group was given with core stability exercises compared to the dynamic neural stabilization with 64 sample size of 64 divided two groups of 32 each. They have basically assessed the balance, the time up and go test for the walking and modified Ashworth scale and trunk impairment scale for as outcome measures. We'll go in detail in the coming slides. Just brief about the introduction of the article. Actually, the authors have mentioned that the studies, of course, there are no studies on dynamic neural stabilization for improving balance and gait in people with MS. However, there are few studies on stroke patients improving the balance and trunk, and also on cerebral palsy. So that might be made them to choose this technique to work on MS patients to compare with the core stability exercises, which has been studied before in MS patient. Like there are few studies, couple of studies, which they have used the core stability exercises on improving the trunk functions and balance. And just a brief about the dynamic neural stabilization technique. It's an comparatively newly evolved techniques, which works on the development pattern of a human being, which combines the techniques of Volta and Lambda. And what I believe is that if you want to practice this, you may need to have a certification of dynamic neural stabilization. I'm not sure about that, but still, it is a combination of three techniques, which they have evolved to be a very new techniques in the field of rehabilitation. Coming into the methodology part, first of all, the study design. Here, the authors have mentioned that it is a superiority randomized controlled trial with two parallel groups. One group receiving the DNS, the dynamic neural stabilization exercises, and second group receiving the core stability exercises. I have a concern about here regarding the superiority design. When we design superiority study, what I believe is that the one group should get uh, like the intervention plus the control treatment, and the other group getting it control treatment alone will be superior because the experimental design will be having a superior protocol. However, this I agree that it is a parallel group design, but here the authors have mentioned about that they have done superiority randomized control trial with two parallel groups. So this is my concern about the design here. Well, the study population, as they have included both men and female, men and women, between the age group of 30 and 50 years, because the most prevalent age group of MS is between 30 and 50. It will be in the middle age group, and they have used the EDSS score, the Expanded Disability Status Scale, which is the yeah, score which we categorize or we assess for disability in patient with MS. They have included the patient with score of 2 and 5, because above 5, a 6 score, which will be patient will be dependent on wheelchair. And they have recruited the patient between the time period of May 2020 to October 2021. So keep in note that this was the time when it was time of peak of pandemic. So that would be a limitation for them. However, we'll discuss that in the coming slides. They have, for the inclusion criteria, they have screened the patients who have cognitive well within the mini-mental MMSE, the mini-mental state examination of 21 and above, patient who could walk and who had fall within last 3 months, so that fall was an outcome measure here, and who are educated to fill up the questionnaires. And patients who are like had any other neurological conditions and lower extremity surgeries or posture abnormalities were excluded from the study. Initially, they recruited the patients who were confirmed with MS from the neurologist, and they were sent to the physical therapy clinic. And here they were block randomized. They have used in permuted block randomization of 16 blocks of 4. That means they had a sample of 64. So they made a block randomization here. Even the randomization was done by a blinded person, and they have used a single blind study here by blinding the assessor who assessed all the outcome measures. And you could see that they have registered the trial in the clinical trial registration by Biomed Central. Coming to the intervention section, all the sessions were performed by physical therapists at home of the patient, because this was during the time of pandemic. And it was done like 3 times in a week for 5 weeks, so a total of 15 sessions. And the days without sessions, they were monitored by text messages. So I wonder how well they can respond to text message for the adherence or compliance of the treatment. For the outcome measures, the work balance scale was taken as the primary outcome measure, because that was the balance was their primary outcome. And they have also used the trunk impairment scale to know the trunk function and trunk function. Time up and go test to know the walking pattern, walking. Yeah. And even they have used the activity specific balance scale, the patient response. It is a patient response scale for balance. And for the posture control, they have used the anticipatory posture control with an instrumented anticipatory posture control equipment. They have used the modified Ashworth scale as well as the multiple sclerosis spasticity scale for measuring the spasticity, and also use the multiple sclerosis walking scale along with the time up and go test for the walking. Here they have mentioned about the exercise protocol they have used for the DNS, the dynamic neural stabilization, as well as the core stability exercises in table 1 and table 2. And they have mentioned the progression from prone to like sit or stand. Well, they have mentioned very briefly, but however, what I believe in the DNS is that first of all, they have to the patients have to learn about how to control the diaphragm, because the whole process or the whole technique depends upon how well we control the diaphragm. That's why I mentioned before, this technique is almost similar to the yoga technique that we use in India. So they have to first learn how to control the diaphragm. So before starting the technique, first they have to learn how to control the buccal diaphragm by tucking in the chin, then control the diaphragm with controlling the transverse abdominis muscle. So in fact, this at itself actually takes some time for the patient to progress from the basic core concept to the first position of supine lying. And in supine lying, actually, they maintain this, they control this, the buccal diaphragm, the normal diaphragm, and then they start the diaphragm and they stabilize the core. Then they start working on the each movement of the upper limbs and lower limbs gradually, not in one session, like gradually from upper limb, then diagonal pattern. So Then they can use the assist balls between the legs, as mentioned in the picture here. So, in fact, this takes time for each patient. Even for the normal individual, it's not easy to maintain this and do these exercises. So, I was wondering how well they could progress this in 5 weeks. So, 5 weeks means it's like 1 month and extra 1 month and 1 week. So, it will be quite difficult for the patient to understand this technique of dynamic neural stabilization. Then progress from one position to another position. And here the authors have mentioned like prone, supine, sitting, and sit to stand. And it is not easy, even for the normal individuals, to stabilize this core concept of diaphragm and the buccal diaphragm and the breathing patterns with the core and progress from prone to sit to stand in 5 weeks. So for the patients, it will be too difficult for them. So, but the authors have mentioned the progression until sit to stand, and they have not mentioned how many patients have progressed from the supine position to standing position. So that is a concern which I really believe in this protocol. Of course, regarding the core stability exercises, here they have it is not that difficult as compared to DNS, because in core stability exercise, of course, we have to control the core muscles, not like the DNS. We have to control the core muscles, coordinating that with the breathing patterns. For the sample size calculation, they have used G-Power software for calculating sample size, where they have maintained the alpha error as 5% and power to be 80%. That's the baseline. I mean, that's a threshold. We cannot go beyond that. And they have used the Cohen's effect size of zero point 0.8. 0.8, actually, the effect size is high effect size. But here they have mentioned that they have not mentioned from where they got the effect size of zero point 0.8, of course, because the zero point 0.8 is a higher effect size. And considering all this, the sample size is like 26 subjects in each group, but they have taken 32 subjects in each group, assuming a 20% dropout rate. Of course, we should expect a 10 to 20% of dropout during the whole study period. Well, in the data analysis, they have used SPSS version 22 for the analysis of data. They have used like sharp probability test for the assuming testing normality. And here for the comparison of the baseline data or demographic data, they have used either man-Whitney U test or independent t-test for comparing between two groups for the demographic and baseline data. And later on, for comparing between the two groups for the outcome measures, they have used the two-factor repeated measure ANOVA. So here, I would like to really like comment on that. Uh, Conventionally, we use to comparing between two groups for the outcome measures, we use the independent t-test, and comparing between pre and post, we use the dependent t-test. However, the outcome measures were analyzed in 3 time points: one the before treatment, the baseline, and the T1, T0, the T1, the post-treatment, and this another one more assessment at 3 at the follow-up at 17 weeks. So this actually makes the study much more interesting, where they have used 3 time points of assessment. So conventionally, when we use an statistical tool for comparing between 3 time points, we should use a repeated measure ANOVA. And comparing between two groups, we have two groups. So comparing between two groups, they use the independent t-test. So, if you look into the articles published recently, you could find that they are using the either the two-way ANOVA, or two-way, it's called split model ANOVA or mixed model ANOVA. Here they have used a two-factor repeated measure ANOVA, because they have 3 time points of assessment. So here they take into account all the 3 time points plus the two groups into consideration and do the analysis. So we get the results in one shot. Okay. For the 3 time points, for that they have used the post-hoc analysis with Bonferroni correction. Okay. So here they could control the alpha error. That's why recently you could find in articles published in very good journal like RCTs, they have used the 2V ANOVA or mixed model ANOVA or split model ANOVA. Okay. This is the consort flowchart for the study. And consort is a guideline that everyone has to use while reporting randomized control trial. So I will post the link of the consort website where you can find the consort guideline and consort flowchart, where you have to follow all the like items in the consort checklist. That is around 26 items you have to follow while doing an RCT or reporting an RCT. Here you can find that they have assessed for eligibility for 70 patients and 6 were excluded for the criteria. The rest 64 were randomized to 2 groups of 32 each. And during the treatment session, they lost to follow up were 29 in the DNS group, three dropouts, and which made 29 at the end of analysis, and 2 dropouts in the co-stability group, which made them to analyze 30. But however, they have used the intention to treat analysis, and they have so that they maintain the sample size to be 32 in each group at the end of the analysis. Well, here they have used 2 groups, as I mentioned before. So there are 2 parallel groups, and there's no control group. So preferably the title should be like a randomized clinical trial, preferably. You can also keep it. There is no like set guidelines that the title should be the clinical study. You can also keep the title as randomized controlled trial or randomized clinical trial. Okay. This is a table which mentions the baseline characteristics of both groups. And if you look into the p-values, none of them are significant. So on the baseline, both the groups were showing like equal values or were not different in the baseline. So that is one of the criteria that we look forward to analyze the further data. When the data or the outcome measures or baseline demographics are equal in the beginning of the study, so that makes eligibility that we can analyze the further data. And how we can make sure about this is by randomization. When we do a proper randomization, we can make sure that both the groups are equally behaving during the baseline. Here in this table 4, you can see the results of the primary outcome measure, that is the work balance scale. And I will explain detail about this table so that it would be easy for you to understand the next table. Here they have taken the 3 time points, the evaluation time, T0, T1, and T2, as I mentioned before. The pre-assessment is T0, post-assessment is T1, and the T2 is after 17 weeks. And they have 2 groups of treatment, like one is the DNS, the other one is the co-stability exercises. They have mentioned the mean and standard deviation for both values of both groups of BBS outcome measure. And after that, you can see the group results. You can see the p values here. It's 0.02, and that means that between groups, without considering the time, it is significant. And you can also see the partial eta square. That's the effect size. Usually, sometimes we take the effect size as coherent. Now it's a partial eta square. So how we interpret partial eta square is any values above 0.14, it's a large effect size. Values above 0.06 is moderate effect size, and values above 0.01 is like low effect size, small effect size. So here you could find it's 0.08. So that we can say it is having an large effect medium effect size. And next, you can find the time. So time means between pre and post, pre and post, and pre and T2. Okay, it's between T0 and T1, T0 and T2, and T1 and T1 and T2. The TP value is highly significant with an like large effect size. The last column, which is more important for us, is the time in the group interaction. So as I mentioned before during the introduction of the statistical analysis, Here they have taken into account the each time point within between the two groups. That is group into time interaction. So there you can find the p-value is 0.001. So it's highly significant within a high effect size. So maybe if you just want to look into the results, so you can look into the last section, that's group into time interaction. That is considering the time, each time point between the two groups. That says that between the time each two groups, that's highly significant, and is more towards the DNS group. How we can understand that? By looking into the mean and standard deviation values of like T2, the time point of the DNS group, or T1 and T2 time points of the DNS group. In this table, the table 5, they have mentioned about all the other outcome measures other than the primary outcome measure, the posture stability, the trunk impairment, the fall rate, the balance using ABC scale, the speed of walking by time up and go test, and the spasticity. So here you could find the last column. You can find the group into time interaction. It's significant for all the variables when comparing between group into time, with a very good partial eta square of eta square for almost all the values. But however, for the group, just for the group, between the group, it's significant only for the posture stability and the trunk impairment scale. But if you look into the time, that means between T0, T1, and T2, all the groups, all the outcome measures have significant p-values with a good partial eta square of having like some of the values having high effect size and some with moderate effect size, but most of them are with a high effect size. Yeah. So this is how you interpret the result section. So you can say that between group into time interaction, all the values have performed well with a significant p-values for all the outcome measures. I'm not much going into the discussion session here because our primary objective was to concentrate more on the methodology and the results. Well, in the discussion, even the authors have mentioned that this is the first study which were working on the effectiveness of DNS techniques on patients with MS. So there is no studies to compare with, no previous studies to compare with regarding the positive results or negative results of the study. But however, they have compared this with the previous studies worked on, which was working on the stroke and cerebral palsy. And even the previous studies, which was working on the stroke and cerebral palsy, they have given positive results towards the DNS group. Regarding the limitations, as I mentioned before, they were working mostly on the pandemic time. So how well they could manage the patients for the follow-up and the adherence and the complaints are not sure. And they have used only the patient with a remitting relapsing type. So it's a one type of the MS. So this may affect the study. And they have also mentioned the recruitment bias because some of the patients will be more interested in physical activity. Anyways, the first two concerns about me was the time duration of the study. It was done on during the peak of pandemic, and the second one was they have used only the remitting relapsing type. But the second one, because majority of the patients which we used for the studies will be a remitting relapsing type, and they have considered only the patient with an EDS score of with less than 5. So mostly those patients will be in the initial stages of MS of diagnosis, and patients will be in the remitting relapsing type. Okay. Well, I have posted here the consort checklist, as I mentioned before, and also the link for the consort website or the Equator website where we can find the consort checklist and consort guideline. And the second one, which I have posted here, the link for Pedro. So we can search the study here, and you can find that the Pedro has given a score of 8 out of 10 because there are certain criteria for that's a risk of bias assessment, or they have critical appraisal checklist by Pedro. Here you can see they're given 8 out of 10 because they have the 2 points they have missed. One is the blinding of the patient and blinding of the physical therapist. Except that they have covered all the topics in the Pedro checklist, where we check the, it's used to check the critical appraisal. We can use any of the scales, like Pedro scale is more inclined to physical therapy or rehabilitation. You can either use CASP, the CASP checklist, or the Cochrane checklist. We can have multiple checklists. Okay, so that's about the journal club for this month. And if you have any queries or to be discussed in the group, you are welcome to mention your queries or post your queries in the group. Thank you.